Good afternoon. I'd like to thank Alexandra Chi and the scientific committee for inviting me to speak, and I'm going to talk about implementation of a Celiac Plexus SBRT program. These are my disclosures, none of which are relevant. So the goals are to explain what is Celiac Plexus radiosurgery, how to run an international trial, and the bottom line is how do we go from the drawing board to inclusion within NCCN guidelines in under $1 million. Our learning objectives are to explain how we plan the study and try to help you based upon our experience with future projects. This is an overview of the talk, the clinical problem, the initial clinical trial, how we see funding, how we put the trial together, QA budget software, what were our outcomes, how do we succeed, where were we challenged, how could we have done better, and what are our conclusions and next steps. So pancreatic cancer pain is an unmet clinical need. Approximately 90% of pancreatic cancer patients suffer from this pain. It's associated with depression, poor quality of life, and decreased survival, and it's thought to be due to infiltration or pressure upon a mesh of nerves in the retroperitoneum, which sits immediately posterior to the pancreas, called the celiac plexus. How does one treat this pain? Well, there are opioid analgesics, and in many patients these are good enough, but there are some patients who require very high doses which create severe side effects. There's chemotherapy, which can be efficient, effective, however typically short-lived, and the textbook solution is a celiac plexus block. This is when local anesthetic is infiltrated around the celiac plexus using either a posterior, as you can see in the picture, or approach, or via the esophagus. If instead of local anesthetic one uses a neurolytic agent such as ethanol, then it's called a celiac plexus neurolysis. So we were a little disappointed by the results of celiac plexus block that we saw in our medical center, and so about a decade ago, together with a talented resident called David Hausner, we put together a clinical trial. The idea was to target the celiac plexus. I didn't know where it was, so we read the literature that's used by the interventional radiologist and the gastroenterologist to define where it is. So initially we used 5 fractions of 9 gray. You can't see the plexus, so we used the abdominal aorta as a surrogate marker from the 12th thoracic to the 2nd lumbar vertebra inclusive. And because the duodenum lies very close to the area, we had a dose painting schema in order to protect the bowel. After about 2 years, we had a crisis meeting. We didn't think it was working. Not many patients completed the treatment. We didn't have much follow-up. And we kind of basically wanted to stop the trial. I wanted to stop the trial, but we said before we stop it, let's just make a last effort. So when we actually looked at that data in that meeting, we actually were surprised to actually see it actually seemed like the treatment may be working. There was enough data there to see some kind of activity. So we decided, let's carry on. We'll just exclude patients with a poor performance status. We'll move to a single fraction to get it all finished in one day, the delivery that is, and we'll also try to move between simulation delivery within under a week. And these are the results we presented in an oral presentation at ASTRO in 2018. We saw decreased pain. You can see here on the left hand side it decreased from baseline to 3 and even more at 6 weeks, and we had decreased pain interference. That's when you ask patients how much does pain interfere with working, activity, sleep, etc., etc., and in the vast majority of patients there was a big improvement. Around that time I visited the ASCO meeting, and I had a fortuitous meeting with a representative from Gateway for Cancer Research, and I said, hello, good afternoon, what do you do? And she said, well, we fund clinical trials that give hope. I said, oh, that's interesting, isn't it? I said, I have a clinical trial that takes away pain, which is associated with depression, hope, maybe we can talk. And we started a dialogue, a letter of intent, and ultimately a grant submission, and we got funding. So this is the international consortium that we ultimately had. Slightly different from the way it was in the grant submission, but we ultimately had 8 medical centers spread across 3 continents. In the United States, we had Ohio State and Mount Sinai. In Canada, we had Princess Margaret, and in Europe, we had Portugal, Poland, and we had 3 centers within Israel. We wrote what we tried to make a very user-friendly and useful clinical protocol. And we did not have any large pharma involved, we didn't have any commercial entities involved, we had no cooperative groups that got involved, and actually we didn't even have an international clinical research organization. So in terms of quality assurance, we put together a comprehensive package, including educational materials. We published a protocol, a number of YouTube videos which are still available. We created a benchmark case for each center. We had a questionnaire on the protocol that each center had to complete. We performed rapid review of the first 3 cases, and we collected all the plans post-treatment. This is our budget of $800,000. Most of the budget went either on research personnel, on the clinical research organization, for the biostatistics, and a little bit of money also for clinical trial indemnity insurance. This is the software we used. We made an effort to use either free or almost free software. So Dropbox for distributing, collecting all the plans, RedCap for the electronic CRF, Google Forms for the quiz, Datos, a company that the hospital works with, and that was for the wearable electronics and for the pain diary. We had used a freeware program called DI Compiler for looking at the radiation plans. I have to say, unfortunately, it doesn't seem to be working as well as it did, and it would be best if we were to do this again to find some kind of replacement. ScreenFlow for the video editing, and YouTube for distributing the educational videos. Accrual, we planned originally to complete accrual in 3 years. Ultimately, it was 4 years precisely. These are our clinical results. Here on the top left, the waterfall plot. Each line is 1 patient. You see the vast majority of patients had improvement in their pain levels. In terms of quality of life, there was an improvement over time. And surprisingly, at the bottom, you can see that actually there was a survival, and there appeared to be a survival advantage amongst those who responded well to the treatment. So how do we do it? How do we complete an international clinical trial on a budget of under $1 million? Well, I think, to be fair, we had a lot of goodwill. This was a trial for dying patients, and people appreciated that. There were no drugs involved, so obviously it made life a lot simpler. We used free or almost free software. The Sheba Medical Center was very supportive as a sponsor. Our quality of life instruments, we received permission to use them free of charge as an academic study. We did no on-site monitoring or audit. Since we were based outside the US, we had slightly lower costs, but not that much lower. We had an excellent biostatistician. We were able to write us some conference rooms, and the PI, I have to say, he worked rather hard. Or the challenges along the way, where we had a pandemic, and that really destroyed some of the inpatient endpoints we wanted to look at, like working and muscle strength. We had some reimbursement issues in the United States. We tried and failed to open the study in Australia, the United Kingdom, and France. The patient diary, we did get results, but not as much as we wanted, and the research associates reported fatigue associated with working with dying patients. What could we have done better? Well, the wearable electronics really didn't pan out in the end, and I can talk offline as to why not. We should have done better remote monitoring as the data come in to check it all made sense. Ultimately, what this meant was when I came to publish the manuscript, I really had to work very hard to clean up all the data, and it would be better had we done that in real time. The electronic CRF could have been designed better. For instance, here you've got a list of some of the variable names that we have, and you can just see that it's a little confusing. It's not a disaster, but it's not the greatest, and we should have really defined those names better. So my acknowledgements, especially to Gateway for Cancer Research, with some additional funding from the Israeli Cancer Association, to all the co-investigators whose names are all listed here, this Sheba Research Authority who really helped me with the study, the patients and their families, research coordinators, and Varian who helped with conference rooms. So that's it. We had a successful trial. We've been incorporated into the NCCN guidelines. We've created a very rich data set we're just beginning to dissect. We still have some clinical questions which are open, and we're currently within the MRG-RTOG mechanism trying to push forward a randomized study of block versus radiosurgery. Apologize that I'm not there in person. Here are my contact details. I'm happy to be in contact with anyone regarding how to do it. You need help, you want to collaborate, happy to talk. Thank you so much.